Welcome! In this explainer, we're going to take a deep dive into the contemporary management of open fractures. We'll be walking through the current evidence-based principles that are just so essential for practicing orthopedic surgeons and, of course, for our trainees coming up through the ranks.
Okay, so let's start with the absolute basics, just to make sure we're all on the same page. What is an open fracture? Well, by its very nature, it's a breach of that protective soft tissue envelope. It directly exposes the bone and the fracture hematoma to all the contaminants in the environment. And really, this single event is what drives our entire management algorithm. It's all about that breach.
All right, let's get into it. Section 1, Initial Assessment and Classification. These first few steps are absolutely paramount because the information we gather right here at the beginning sets the stage for every single treatment decision we make down the line.
A thorough history is just crucial. And, beyond the obvious things like mechanism and timing of the injury, it is so vital to ask about pre-existing conditions. We now have really strong evidence that factors like depression or substance abuse aren't just background noise. They are independent predictors of complications and can seriously impact a patient's functional recovery. Now, this is a number you just have to burn into your memory. It's a definitive clinical action point. During that neurovascular exam, if you have any concern about vascular injury, an ankle brachial index is mandatory. And if you get a value below 0.9, well, that's not a gray area. That is an absolute, hard stop, get on the phone to vascular surgery indication for a consult and most likely an angiogram.
Here we see a perfect example of an evolution in our diagnostic practice. For years, right, the saline load test was the go-to for checking a potential traumatic arthrotomy of the knee. But the recent evidence now strongly favors the CT scan. It's just more sensitive, and it's effectively become the new standard of care in this situation.
Okay, let's shift gears to the emergency department. The actions we take here in these first few hours can dramatically influence the final outcome, especially when it comes to the risk of a fracture-related infection.
Time is absolutely critical, and the evidence on this is unequivocal. There really is a golden window for getting those antibiotics on board. If you delay that initial IV dose beyond 3 hours from the time of injury, you're looking at a statistically significant increase in the deep infection rate. This is without a doubt a key performance indicator for any trauma system.
So our antibiotic strategy is really dictated by two things, the Gustillo classification and the specific contamination profile. For your straightforward type 1 and 2 injuries, a first-generation cephalosporin is going to be sufficient. But once you hit type 3, you got to add an aminoglycoside for that gram-negative coverage. And of course, they're the special cases, right? Farm injuries, you add penicillin for Clostridium. Saltwater immersion, you need to be thinking about Vibrio and cover accordingly.
In the ED, our wound care goals are pretty simple. Stabilize, cover, and prevent any more contamination. You want to remove any gross debris you can see, but, and this is critical, do not go probing the wound or removing bone fragments. Those pieces might be crucial for reconstruction later. Just apply a simple, sterile, saline-soaked dressing and then stabilize the extremity. Aggressive irrigation at this stage is a bad idea. You can actually drive surface contaminants deeper into the wound.
And now we head to the operating room. What happens in here is arguably the single most important determinant of success. Thorough surgical irrigation and debridement. This is the absolute cornerstone of preventing a fracture-related infection.
For years there's been this debate about timing. How soon is soon enough? While this crucial point now has high-level evidence to guide us. The Goliath meta-analysis gives us a strong answer. For all type 3 open fractures, you really need to get that surgical debridement done within 24 hours to minimize the infection risk.
This is a fantastic practice point, and it has some serious resource implications. We've seen multiple studies compare low-pressure bulb irrigation, the simple stuff, to the fancy high-pressure pulse lavage systems. And the data consistently show no difference in infection or union rates. So given that low-pressure irrigation is way less expensive and avoids potential soft tissue damage, it really should be considered the standard of care. When it comes to debridement, there are absolutely no shortcuts. The principles are absolute. You have to extend those wounds so you can see the entire zone of injury. All non-viable tissue, we're talking muscle that doesn't bleed or contract, skin, fat, it all must be sharply excised. Bony fragments that have no soft tissue attachment, they go. And crucially, you have to have a very low threshold to go back to the OR for a second or even a third look every 24 to 48 hours until you are positive that wound bed is clean.
Okay, so once we're confident that we have a definitively clean wound, our focus shifts. We now have these twin goals.
achieving biomechanical stability of the fracture and getting definitive soft tissue coverage to create a closed, biologic envelope. Now this represents a huge shift in our thinking. I'm sure many of us were trained with the old dogma: coverage must be obtained within 72 hours. But the landmark LEAP study really challenged this. It demonstrated that the real priority is achieving a thoroughly debrided, clean wound bed, not just racing against a strict 72-hour clock.
But, and this is a very important but, while the LEAP study gave us some breathing room on that 72-hour rule, the window for coverage is not indefinite. The data show a clear penalty for waiting too long. After 1 week, the odds of infection climb by 16% for each additional day the fracture stays open. This just reinforces the goal of early coverage, ideally within 5 to 7 days.
Now, for those really challenging cases, the ones with critical size segmental bone defects, the masquelette technique has become a real workhorse. It's a reliable, two-stage reconstruction. In stage 1, you do your meticulous debridement and place an antibiotic cement spacer. This spacer induces a biologically active membrane. Then, in a second stage, about 4 to 6 weeks later, that membrane provides a perfect, vascularized envelope to put your bone graft into, along with your definitive fixation. It's a really elegant solution.
And this right here illustrates the ultimate goal of our fixation strategy. Look, external fixation is a fantastic tool for temporary stabilization, but the aim should always be to convert to definitive internal fixation as soon as the soft tissues allow. The evidence is just so clear that this approach leads to faster union, better functional outcomes, and shorter hospital stays for our patients.
All right, let's move into our final section. It's so essential to understand the primary complications we are working so hard to prevent. This understanding informs our technique, and it also shapes our discussions with patients about their prognosis. This bar chart really says it all, doesn't it? The Gastillo classification is still so clinically relevant precisely because it directly correlates with infection risk. As you can see, the likelihood of a fracture-related infection just skyrockets with the severity of that initial soft tissue injury. We're going from less than 1% for a type 1 all the way up to 30% or even more for a severe type 3. So, certain factors should really raise our index of suspicion for that devastating complication of chronic osteomyelitis. These are the red flags: a high-grade Gastillo injury, a blast mechanism, that delay in soft tissue coverage beyond 7 days we just talked about, and, of course, a tibial location thanks to its tenuous blood supply. And it is so critical to remember that an open fracture, especially in high-energy trauma, is almost never an isolated event. About 30% of these patients have other significant injuries. We have to maintain vigilance for associated compartment syndrome, neurovascular injuries, and also the significant psychological impact, including post-injury depression. Comprehensive care absolutely demands a thorough, systemic evaluation. So this leaves us with a critical, systems-based question to take back to our own institutions. The evidence shows us the clinical goals, especially achieving definitive coverage within that 7-day window. The challenge for us is to look at our own logistical pathways, how we coordinate with plastics, how we manage OR time, to make sure our systems are actually built to provide this timely, optimal care. Thank you.